Making healthcare decisions for a family member or friend at the end of life presents many challenges. The video that follows tells the story of one woman's efforts to do that. Anita Baskind became the healthcare agent for her mother, Rosella, as she slipped into dementia over a number of years. Anita's successful relationship with her mother's healthcare team can teach all of us to cope with the hurdles we face in carrying out a loved one's wishes.
We went on that journey of increasing dementia through a long period of time in which she could do certain things, but it was obvious she couldn't do certain things. Had to take away the keys, take away the checkbook, all of the things that you hear about. So 8 years after this journey started, it ended up at the Jewish Home and Hospital for the Aged in the Bronx, and we had to admit her there.
When Mrs. Baskind came in, New York State was just beginning to formulate the healthcare proxy. Even if the healthcare proxy was up and running, she came in at a point where she would no longer understand, so she didn't have the capacity to appoint a healthcare representative. Fortunately, she came in with a loving daughter who acted as her representative.
From a practical point of view, I lived here, and my sister is my only sibling. She lived in Iowa with a family. So just in those terms, it was obvious that I was going to have a major part. And there was no question of it or anything. My sister knew that, and we knew it. So I began to oversee what needed to be overseen.
And one of the things that I did was help Anita understand her role vis-a-vis the team in helping us understand what her mother would have wanted as she lived here and as she began to reach a point where certain decisions, major decisions, had to be made for her.
Family members should be informed of what do we mean when a doctor says to a family member, what are your wishes, or what was your mother's wishes before she was hospitalized about dying.
I don't remember who brought up the DNR. I'm sure I might have known about it, but shortly after she entered, I was asked, and I said I did want to sign one. And they had to go through their examinations. Legally, they had to have 2 doctors examine her to see that she was not competent to make those decisions.
I asked Anita if she recalled conversations that she might have had with her mother, and she did. There were many conversations about end of life, and I asked her to put it in writing, which she did.
I guess there was a history of friends and family and things like that where people had been hooked up, and she and my father would come home from visiting and they would say, oh my goodness, you know, God, why don't they just let them go? Why are they keeping them alive? Or what? So I felt pretty good about interpreting that.
The letter that Anita wrote was wonderful, and what we call it is clear and convincing evidence. And we use a letter of clear and convincing evidence when there's no healthcare proxy. I had her address it to the medical director, and then it filtered its way down to her chart. It was in the front of the chart. Anyone who had any questions about Mrs. Baskind's advance directives could read it.
You know, it seems to me that there are only 2 tasks in life. You bring kids up and bring them into the world and nurture them so they can go on, and you help the other generation get out with a minimum of difficulty. And I began to realize how this was my life. This is what I'm supposed to be doing with my life.
She was very interested in her mother's progress from the beginning. It wasn't just something that happened at the last minute when she was deteriorating. She was always involved, always there. Questions to the doctor, answers.
I read a lot. Anywhere I saw someone talking about it, I'd go.
And she joined us when we invited her to team meetings to sit with the team. She was there talking to us individually. And she was aware of our care plan. She knew that she had an opportunity to be involved.
And that's part of it. That's part of the job. You know, it's not going to be just, oh, sign this.
Anita understood the disease process. She had seen the decline. She was continuing to see it. And her suggestions were based on reality, on what was actually happening. If she thought that occupational therapy was needed, she would suggest it to the team, not demand it, and we would be willing to go along with it.
And the interest brought also some knowledge and education to us, the nursing staff, on her part, because she really had very valid suggestions to offer. So in that light, she was very different.
It was clear to me in the last few months of my mother's life that she was taking in less and less food. She, of course, had to be fed for a long time now, but she was taking in less.
Someone mentioned about, what about inserting a GT tube to give artificial feeding? And I do know that Anita was extremely upset about this.
I think I harbored in my mind that she would die of stroke. She'd have a massive stroke, she'd have a massive heart attack, she'd get pneumonia. I mean, those are easy. I guess I didn't really understand that what might happen, even though I had read about it in terms of Alzheimer's, is that she would starve to death.
A lot of times, at the end of life, you just don't feel like eating. Our society does not tell people that. We don't realize that there is often a natural way of dying where the stomach shrinks, the appetite diminishes. A little bit is enough.
Lots of family members may want to ask, is she hungry? Will she know that she's hungry? Will she be thirsty? And we would reassure the family member, because a lot of the research states that once someone's intake is decreased, they really do not experience hunger and thirst.
Every time I would think about it, or it would come to the fore, this is not easy. And I needed to reaffirm for myself each time, not because I really felt I was making the wrong decision. That's not it, and I don't want to imply that. I had no doubt that I was doing what I felt she would want me to do. But nevertheless, you are stuck with the concept of allowing someone not to get food. I got a phone call. It was from a doctor at the home, not one that I knew. It was not the regular doctor. It was the attending doctor for that time. Somebody drew New Year's Eve duty. And he said, Miss Baskin, I'm calling you. Your mother has a urinary, it was very measured, very calm. Your mother has a urinary tract infection, and we'd like to treat this with antibiotics intravenously. But I noticed in the chart that you said no tubes, and so we have to ask you.
There was a known statement in the chart that, the IV, or tubes, so to speak, were not wanted. I think at that point it's incumbent upon any physician or healthcare provider to contact, the contact person to ask us, do we want to temporarily suspend that? Because that's actually what we were talking about, sort of a temporary suspension of that, of that clause.
At the Jewish home, we make it clear that there is not a lot of difference between withholding and withdrawing, so that people can feel comfortable knowing that they can start a medical procedure, and if they feel that it's really not working out, the quality of life is not improving, then they can ask that it be withdrawn.
So I said, well, that's okay. I mean, treating her with antibiotics is fine if you need to do it intravenously. I said, but how can I guarantee that no tubes will remain and that this is the only purpose for the tubes? He said, I'm writing it in the chart.
I put in big capital letters, the daughter is to be contacted for any significant change, so that any physician, other than myself, who would, review the chart and be in the position of caring for this person would see that.
About an hour or so later, he called and he said, we're having some trouble getting the intravenous in. Her veins are pretty collapsed.
I initially thought that, having, the IV could relieve whatever discomfort that the infection was causing. However, at such point where I could see that starting an IV was going to be problematic, I thought it was best to, just reconsider. And that's why I called her the second time, to just, to be clear on, what direction we're going. And that's when I just reviewed the whole concept of, comfort care, and so that way we could both be on the same page with what we were doing.
He said, we're also giving her a little oxygen. She's having some trouble breathing. So I said, sounds like I should get in the car. And he said, well, maybe that would be a good idea. So I gave him our cell phone, and we were in the car, and about 45 minutes from the time of getting there, he called back and said that she had died. I had always hoped I'd be around at the time, but that's how they followed the care plan, and I'm very grateful for that. I think my words to him were, thank you for what you've done and what you didn't do. So that was the end, and other people might have made other decisions. I still think I made the right decision, and I still think it was very hard.
The video that follows focuses on the relationship between two people. One, the principal, is choosing someone to carry out healthcare decisions at the end of life when she is no longer able to do so. The other, the agent, will be her representative. The conversations they will have are crucial. Principal and agent must focus not only on values and philosophy of life, but also on practical matters, such as communicating with other family members and the medical team. Their ultimate goal is to see that the principal's final wishes are carried out. What follows are two such conversations.
I've been talking to you a little bit on the telephone about the fact that Daddy and I are redoing our wills, and so we're redoing the proxy statement. And so Daddy's going to be my primary person, and I'm going to be his.
Years ago, one just did not discuss death. We knew it was imminent, but we just did not discuss it. We're now in a process of change where we're discussing it.
And I need another person to sort of carry out my wishes for me.
Okay.
And, I thought about Emily because she's the oldest, but you're the medical student.
It's very helpful if before the parent is ill, they had ongoing discussions in the family.
And I think it's really obligatory to have a conversation where, the question is asked, what would you want, what would you not want?
I mean, I know we've talked a lot about how I feel about sort of if something should happen to me, what I want done and what I don't, but I need more specific conversation.
Okay.
We look for a philosophy of life. What is your philosophy? What do you consider a quality life? Have you thought about the end?
I, Juliette Louise Gumbs, being of sound mind, willfully and voluntarily make known my desires, that my dying shall not be artificially prolonged under the circumstances set forth below.
Just because we have the technology, would you want to use it, or say, no, this is not something that I would want?
Would you not want artificial breathing? Would you not want a feeding tube? Would you not want blood transfusions? Would you not want an intravenous line?
I feel especially strongly about the following forms of treatment. I do not want artificial feeding or hydration by gastric tube, intravenously, or by any other artificial or intrusive means. I do not want cardiac or pulmonary resuscitation. I direct that such procedures be withheld or withdrawn, with only the administration of medication or other medical treatment necessary to keep me comfortable and to relieve pain, including the pain that might occur by withholding or withdrawing treatment.
So I guess there are a bunch of different scenarios that could happen. So let's talk about the car accident or
Okay.
the scenario, because that happens fast.
So what do you think? What do you think you would want?
Well,
in
I
that
would want to be
situation?
kept alive if there was any chance that I could recover and have life with quality.
So if they said 5%, you'd want me to keep you on.
5% that I would make a recovery so that I could lead a life that I like to lead. 5% is a pretty small percentage.
How long would you want to? I mean, if they said maybe like there's a 20% chance and you'd have to be on a ventilator for 6 months.
And at the end of the 6 months, they felt that I could
Yeah.
lead I would do that.
Okay.
You know that I, unlike everyone else in our family, I believe that being alive is really important.
Okay.
So I would want you to keep me alive unless it became clear to you that no matter what was done, that I couldn't have a meaningful life. By meaningful, I mean that I couldn't be able to relate to other people, that I wouldn't be able, I could be in a wheelchair. That
So
would be okay.
physically, you wouldn't be okay if you were physically disabled, but just not
Yeah,
like mentally.
I would be okay if I was, almost any physical disability
Okay.
I think I could deal with
Okay.
pretty much. Except I don't want not to be in pain all the time.
Okay. So it's more the mental.
Right, and the ability to
stuff that
relate to
worries
people
you.
and to
Okay.
recognize people and to be who I am. Because
Okay.
I don't think that my physical abilities define who I am,
Okay.
but my mental capacities and my relating capacities do.
I mean, I think the only thing that makes me a little uncomfortable is the 5%, like the really like slim. Yes, there is some possibility she may fully recover, but it's so unlikely. And I think that I feel like maybe I wouldn't make the right choice in that situation for you. What if they said yes, there's a slight chance, and then I would sort of worry like what if it's not enough of a chance, and then I would have to watch you sort of suffer. I mean, this is the first time we've talked about that aspect of what you would want, and so I think I just need to think about it a little bit more. But if that's really what you wanted, then I would do that.
I think this is an imperfect process. It can't be done 100%
Yeah,
because it's theoretical.
yeah.
I think that's what I want, but I've never had anything really
Yeah.
wrong with me, and I've never had a serious illness,
Yeah.
and I've never been in a lot of pain, so I think that I would be willing to go through a lot. The main things are I don't want to be trapped in my body and not able to communicate, and I don't want to be in terrible pain. I think that for even a relatively small chance of having a recovery that would leave me in the way that I would like to be, I would be willing to go through stuff.
Okay. So you'd want the whole 9 yards if there was some chance that you would get better.
Yeah.
And even if you had to experience some pain and some fear through that process, if you felt like there was a chance you could have a full recovery, you'd want that.
Right.
But if you were going to be in a lot of pain,
If I had terminal cancer and we were past the point of surgery and chemotherapy and analgesics and all of that, then I think I would want to be kept physically, then hospice is what
Right.
appeals to me. So I'd like to be kept as physically comfortable as I could be. And I know that that's doable. Pain management is good. And I'd like my family to be there as much as possible. And then I'd like to be allowed to die peacefully.
Okay.
Do you think you could do that? Okay. Well, I've talked to Daddy about it, and he says he thinks he could, but I'm not so sure that he could.
I know you well, and I know what you would and what you wouldn't want. And I think that Dad isn't always as good at seeing that, or I think he might be less able to emotionally disconnect from the situation and look at really what you would want as opposed to how he would be feeling about the situation. And I think that even though I would be obviously distraught if anything terrible happened to you and I had to watch you suffer or watch you be sick, I think I could separate that and look at you and what you would want and agree to respect that, even though I might not make that choice myself.
So I'm comfortable with that. I'm comfortable that you would do what you felt I would want you to do.
As a good healthcare agent, you need to know just what the person wants, what they don't want, and then when the time comes and the person enters a hospital or nursing home, communicate that as fully as possible to the healthcare providers.
When one waits until there's imminent death or the person is terminally ill, then it compounds the whole problem. It's very difficult to make the decision at that time.
Of course, it does take a lot of tact and diplomacy, but I think if you can somehow come around to discuss it with the person in question, with the person that you're acting as an agent for, it can be very helpful down the line.
The initial one about hydration and feeding, that I feel particularly strongly about because, as you know, I was the health proxy for my aunt when she was dying of stomach cancer.
So you're telling me that you don't want any feeding whatsoever,
That is correct.
intravenously or otherwise?
Right. And
So I'm not quite sure. Does that mean that if you're unconscious, you're at the hospital, and you know how they feed you every couple of hours, you're telling me you don't want that?
if I'm terminal in the
Okay.
ways that I've stated, okay, then I don't want extraordinary methods employed to make
Okay.
it possible for nutrition to go into my system, whether it's by IV or whether it's by gastric tubes.
Okay.
Wet my lips, make me comfortable, but I'm on my way out. So don't impede that process. What's disturbing you about what I've said in terms of?
Well, you know, supposedly if it's terminal, well, maybe if it isn't terminal I could understand. But if there's still hope that you can go 50-50, I would like to say, hey, you know, maybe we should do the feeding.
But the thing is, you still have the options, okay? Understand that.
Oh, so if I said, yes, they could feed you, you're okay with that?
The reason I did the laundry list kind of, if I am terminal, I do not want, I do not want, I do not want, was just to make it easier for you to say no and to have less hassle from doctors or family members of mine. I wanted them to know I was very clear that these things were a no-go, okay? There might be other things that you will have to make a decision on, but I figured I would set a pattern for you so that you would know where I'm going. I mean, all I want is pain relief at the end. You know, probably what I want is a hospice situation. If I'm terminal, I want to be comfortable.
It is a difficult choice to make. When you do it for somebody you care about, it's hard. It's final. It's very final.
I know it's tough. You've got to trust your instincts. I trust you, just as my aunt trusted me to do the right thing. Because I know you love me as I loved her. I couldn't pick a better agent, I feel, than you, because you've known me, as you said, all of our lives since we were 10.
Yes.
Now, of course, I am the oldest of 4 children, so it's something that I have to bring up with them again and to remind them that I've made my wishes known and I've put it down in writing and that you are my proxy, not one of them. Okay?
Why didn't you pick one of them?
Well, first of all, proximity. You're here in New York and I'm in New York. So when it comes to decisions, I figured the people who are closest physically and who are closest to me emotionally should be the ones to make the decision.
I don't think that I would have a problem with Emily and Joey because they know we date back from way back when. I don't think they would give me a hard time, but I wouldn't be opposed for their suggestion. But then I would also bring it back to the table is, this is not what she wants.
Right.
And I'm going to have to say that since we've known each other for so long, that I like them to respect my wishes. Everybody will always have something to say. That's a given. But the bottom line is you do what you feel is right, and you do the wishes.
See, I know you will stick to my wishes no matter who comes up with outside agendas.
It's scary though, but I guess it has to be done.
It is, I think, a gift and a last gift in that you're doing what the person would have wanted.
It's a matter of the courage to carry out a family member's wishes, even if it's not your wishes. It's the mitzvah.